Hello, friends. I'm Dr. Over-Reliance. I am GP in NHS Scotland, and I'm very pleased to have Dr. Lachlan Calder with me. He is a friend, a colleague. He also works with as a GP in NHS Scotland. Thank you, Lachlan, for joining in.
Thank you very much
Um,
for having me.
Thank you. Today, I mean, he has very kindly agreed to discuss a recent editorial on in British Journal of General Practice on asthma deaths in children in the UK, the last straw. This was written by Dr. Levy and et al. I think we will just directly jump into it, Lachlan, if
Yeah,
you don't mind,
yeah,
and if you could just quickly give us a short overview of the case, like as to what happened in the case of William Gray, the wee boy, and what were the main issues identified.
Thank you, Avril. Yes, well, Dr. Levy is discussing the case of William Gray, who's a 10-year-old boy who unfortunately passed away of a severe asthma attack. And he mentions there were a number of warning signs before this incident that really should have given the doctors clues as that he was at a life-threatening risk of an asthma attack, and he'd previously been admitted before into the hospital and discharged after 4 hours, despite having a severe life-threatening asthma attack. He was repeatedly managed with courses of oral steroids and with Salbutamol inhaler, commonly known as the blue inhaler in the UK. However, he didn't have a regular prescription of an inhaled corticosteroid inhaler. And Dr. Levy talks about this case and some of the things that happened that perhaps led to the death of William Gray, and discusses how there were a number of other similar situations and excess number of child deaths in the UK due to asthma.
Right, right. And I understand from the write-up, the editorial, that this child, on his way to the hospital, he was even given adrenaline, and even then he was discharged 4 hours later. And just to quickly clarify to the audience also, difference between the salbutamol inhaler and the ICS, the inhaled corticosteroid inhaler. I mean, what are these? And just for our patients, so that they can understand what we're talking about.
Yes, so the two main types of inhalers that we might use for asthma are a salbutamol inhaler, which is a short-acting bronchodilator. Now, it's got a very short period, as it includes the name, a short-acting inhaler. It's got a short period of time where it reduces, it works really to open up the airway. Now, this is commonly called a blue inhaler, and you'll often see patients carrying their blue inhaler, or children are given a blue inhaler. And that was the inhaler that William Gray in this case was given. Now, the other type of inhaler that Dr. Levy is really encouraging GPs to prescribe is a steroid inhaler. So that might be brown in color, or in some cases it might be pink in color, depending on the manufacturer or the brand. But this is steroids more work to reduce inflammation, and really what we're recommending is that steroid inhalers should be prescribed for children, and really there's good medical evidence that they're indicated and really should be prescribed for children with asthma.
Right. Okay. Thank you for that. So about this case we're talking about, because there was all this inquiry into it, and there's a big judgment after this. But if you could recall, what are the major like failings in William Gray's case as identified by the coroner, and how did the lack of ICS, or the inhaled corticosteroids, they contributed to his death?
Well, William had a number of exacerbations of his asthma before, yet, as far as I understand, he wasn't under the care of an asthma specialist. Now, one of the recommendations is that children who are having frequent exacerbations of asthma, maybe two or more in a year, or children who are having a life-threatening exacerbation of asthma, they really should be under an asthma specialist. Now, that would be maybe a qualified respiratory physician who most likely works in a children's hospital, who would have an expert knowledge of asthma. And the suggestion is that there are probably not enough children under specialist care who have had life-threatening exacerbations of asthma, or frequent minor exacerbations, who really should be under specialist care. Now, as GPs, we've got a good deal of knowledge of asthma, and really we deal with asthma every week in the practice. But there are specialist physicians who would have more knowledge than us, and often we'll find in general practice that actually the practice nurse has a good deal of knowledge of asthma, but still. Despite the knowledge of our practice nurses, really we should be identifying patients who've had life-threatening features and referring them proactively to the respiratory department. So that was one of the key findings. The other finding was really about a lack of prescription of preventer steroid inhalers. Those inhalers I was talking about, brown-coloured inhaler typically, or pink-coloured in some cases, inhaler which should really be prescribed for those patients who've been diagnosed with asthma.
Right. So despite him being prescribed oral steroids for acute events, there was not enough of inhaled corticosteroids, inhaled steroid inhalers that could have actually prevented the exacerbations or even the acute attacks, basically.
Yeah. Levy talks about how asthma is often treated as an acute illness rather than a long-term chronic illness. And just giving children short courses of high-dose oral steroids for short periods of time to deal with an acute illness is not really appropriate treatment. We should be more treating chronically. So every day giving a dose of inhaled corticosteroid via the inhaler rather than having no steroid most of the time and then suddenly getting a very high dose of tablet steroid during an acute illness, which is not really how it should be managed. It should be managed on a chronic way.
Right. And also, I mean, from this write-up, I learned that UK has the highest number of asthma deaths among children in Europe, which is quite worrying. Yeah. We have all these nice guidelines to go with, and still, the other thing was, I mean, we mentioned about insufficient ICS use, but and also the lack of specialist referral after severe attacks as key preventable factors which should have been addressed. But then there's a mention of excessive SABA use or excessive salbutamol inhaler, the blue inhaler use. Why was that excessive use of short acting or the blue inhaler a problem in this case?
Well, the really repeated overuse of this short-term salbutamol inhaler, so the blue-coloured inhaler that people often talk about, repeated overuse of this, it has been recognised that it's really not how asthma should be treated for children, and it can be a key indicator. So patients who are requiring 3 or more salbutamol inhalers within a year are at high risk of further exacerbations of asthma. So it should be a key indicator for us to know in our patients. If we see that our patients are frequently requesting salbutamol inhalers, that should be a sign to us as GPs or as practice nurses that we need to review this patient. We need to bring them into the practice or have a discussion about how is this patient's asthma being managed. Do they need specialist referral? Do we need to change their preventer inhaler, possibly their steroid inhaler? Or do we, is their compliance with the inhaler not very good? Maybe they're not taking it properly or not getting not enough of the inhaler dose in when they're breathing it in. So it really should flag it up for us for review that if a patient is overusing these salbutamol blue inhalers.
Right. Yes. So talking about the salbutamol inhalers, also I wish to cover this point. We were talking about it earlier about multiple inhalers being issued, and Dr. Levy mentions it that could be a problem from GP's perspective, that we are issuing more than one salbutamol inhaler at a time. So what could be, from GP's point of view, what could be those practicalities wherein we do issue multiple ones, and how we can mitigate those to prevent these kind of situations of sudden deaths?
Yeah, well, I have to admit, Dr. Vats, that myself, I do sometimes issue multiple salbutamol inhalers. Now, there can be multiple reasons for that. You have a school-age child or a nursery-age child. They may want one inhaler for their house or one inhaler for their school bag, or their wherever they're going, or perhaps they're going on holiday and they're worried that they'll run out of their inhaler, and so we issue another salbutamol inhaler, or they lose it, or they lose their inhaler. I mean, children lose things all the time, so practically we have to issue replacement inhalers fairly regularly because children lose them or drop them or don't use them properly. So practically there may be times where we're having to issue multiple salbutamol inhalers. But I think that this article has challenged me to look at it and say, well, I think we need to be more cautious about overusing these salbutamol inhalers. They have their place, but overuse does seem to be linked to patients suffering exacerbations of asthma, and is there some underlying science behind that the frequent use of short-acting salbutamol inhalers is leading to more inflammation in the respiratory passageways? That could need to be looked at and really validated. But I think we'll need to have a look at our prescribing. Prescribing practice, as for example, for a general practice, we'll need to have a look at those patients who are prescribing more salbutamol, who are the patients who are getting more salbutamol inhalers than perhaps they should be getting, and seeing, do these patients need review?
Yeah, and I think to add to that, I mean, if we are prescribing, for the practicalities you mentioned, if we are prescribing more than one inhaler at a time, we do need to educate the patient or the parents, or that if you are using it so many times a week, or then the use is amplified like that, so that is a trigger for them to get back in touch, so that their ICS inhaler can be reviewed. I have a very recent example of this. Just the other day, I had a patient, an adult patient, and she came to me for a review because she had asked for her ICS inhaler, which she has not asked for in last 2 years. And then obviously, she was asked for a review, and then she said that she's only using it seasonally. She has asthma. She only uses it seasonally, and that is why she has one from last 2 years, and it's still in date. So she was using it. But after reading this editorial and going in a bit more detail, I explained to her what the role of an ICS was, how it brings down inflammation and then prevents the acute attack. She was actually, immediately she said, "Oh, I didn't know that. Thanks for telling me. And then I am going to use it very regularly, even if it's like once a day or twice a day, whatever the prescribed dose is." So that was my experience. Did you have any such similar experience of highlighting this?
Yeah, that story that you tell, I think, is a common story that I hear. I wouldn't say most patients, a good number of patients really don't understand the purpose of their steroid inhaler. They get the immediate relief from the blue salbutamol inhaler that they're commonly prescribed, but they don't quite get the same relief perhaps from their steroid inhaler. And so some people say, well, I don't see the point in taking it. So I think what you're highlighting is a very common story. This week I had a patient also that had come into my surgery after having had a life-threatening asthma exacerbation over the weekend. And that immediately triggered in my mind, well, this is the sort of patient that should be under a specialist asthma clinic. And lo and behold, looking in the notes, they were not under the care of a respiratory physician. So again, having read this paper, it immediately triggered in my mind, I need to get a referral sent off to the local children's hospital as soon as possible, so they're aware of this child who's had a life-threatening exacerbation. That's been done, and I do hope that they will get the care that they need, for sure.
There you go. I mean, it probably is very common what you just mentioned. That's why we have already experienced this. So this is quite a timely write-up, and rightly so, because there has been multiple cases of these deaths, sad deaths, where children have died because of acute asthma, and there has been a national review of asthma deaths. Which you mentioned in Dr. Levy's editorial too. So could you quickly summarize what are the systemic causes, as in what are the key findings and recommendations of this national review of asthma deaths?
Well, first of all, not enough children under specialist care. So children who are having severe asthma, not under specialist care. So again, reiterating that those who've got life-threatening asthmatic features or frequent exacerbations need to be under specialist care. Furthermore, prescribing preventer inhalers such as steroids. All children who are experiencing asthma symptoms really should be having a prescribed steroid inhaler. There needs to be means of review within the practice. So general practice, we need to be finding those patients, those children who are having exacerbations, and ensuring they've got an asthma plan. so that they can manage the case. They know what to do to should they be having exacerbation symptoms of asthma. So yeah, identifying those patients and ensuring that they're regularly reviewed. This idea of an annual review of asthma, sure, it's got its place, but we really need to be more proactive than just leaving things for 1 year, and really reviewing more often than that for those patients with life-threatening features of asthma.
Right. Right. I mean, having gone through this, I think a key thing is what is the urgent action? What are the urgent actions needed as such to improve the situation? I mean, we have talked about them bits and pieces, but if you just want to kind of enlist a few of those, what in your view could be those urgent actions which should be taken to prevent this?
Yeah, so I think we've got to look at things both at a national level and at a local level. So as us two as GPs, we can identify those patients in our practice who have had life-threatening features. We can review them. We can bring them into the surgery. We can ensure that they're not just getting short doses of steroid, oral steroid tablets, or multiple salbutamol inhalers without regular review. We can ensure they're referred. We've also got to look at things nationally, and that's going to take more work and more effort. Now, there are multiple factors why people have exacerbations of asthma. And, I'm sure there is a genetic component to asthma, but we've also got to look at society as well. We've got to look at pollution. There are certain cities in the UK where the air quality is considered poor, and this is something that has been identified, and we're now having clean air zones within major cities. You look at Glasgow, Edinburgh, Aberdeen, Dundee in Scotland. We're now having low emission zones. Well, there's political pros and cons to that. Some people will be unhappy they can't drive their polluting car in the city centre, but that'll be countered by those who are pleased that they have less polluted air. So these are national strategies that depending on your political views may well be important. I would suggest that given the government has had a number of cases recently, and in particular there's a case down in England where the level of pollution was believed as being one of the factors in the death of a child from an asthma exacerbation. I think this is going to be looked at increasingly in the national discussion about air quality and the link there with exacerbation of asthma. So that's a national strategy. I think furthermore, there'll need to be a review of the guidelines at a national level. Now I'm talking more about organisations like the British Thoracic Society, the NICE guidelines, looking at prescriptions and being more clear about what inhalers should be used for children with exacerbations. Levy talks recently, I think in one of his podcasts, about instead of using a salbutamol inhaler for exacerbations, perhaps using something like Symbicort or other inhaler brands that contain both a long-acting beta-2 agonist and steroid as well in a combination. So there may be a need to review these guidelines and say, look, is the inhaler therapy that we're using actually the best treatment for children with asthma exacerbations?
Right. So moving on, so if we were to address the general public, so what are the signs and symptoms of a poorly controlled asthma should parents and caregivers be aware of, and how can they advocate for better care and follow up for their children? If they are listening to this podcast, what are those things which they should look at, and how they should approach their GPs and other clinicians?
Yeah, so one of the signs I'd say is, is your child coughing a lot? Are they coughing all the time? Are they coughing more at night? Is their sleep quality being affected? Are they getting breathless all the time? Are they going blue in the face and not being able to keep up with other children in the school playground? Are they getting frequent chest infections? So there's lots of features that should make you trigger concern and seek advice either from your practice nurse or your GP. But I think if you're concerned about your child's breathing, if you're concerned about their cough, then you should attend for a routine review appointment. And that should really make you think, look, is the inhaler therapy my child's getting really enough? Is it, doesn't need reviewed? And just saying, well, I'll leave it to next year because we've got another year review appointment. But I would say, please don't do that. Please go and see your GP or your practice nurse sooner than that, and get some advice.
No, indeed. I mean, yeah, indeed. I totally agree with that. If the child is, or any patient is using frequent use of reliever inhalers, or has persistent symptoms, as you mentioned, Dr. Calder, and multiple asthma attacks, so those are big red flags, and they should be addressed with the comprehensive asthma action plans, and also regular follow-ups and specialty referrals wherever necessary. So to conclude, to wind it up, so what do you think from the kind of healthcare system perspective, what should be the next steps? Because what we are discussing today, there has been a huge inquiry into it, and there is the verdict is such that the concerned institution, the bodies, they have to take steps, and then then highlight what steps they have taken so that this doesn't happen again. So this is a huge thing, and it's not the first time. I think it has happened, if I'm not wrong, 4 or 5 times with asthma deaths. So, but still we are there, that things have not changed a lot. So what are the next steps for healthcare systems and policymakers, not only in UK but in general, to address these issues which I mentioned here?
Well, I think it requires a culture change. If we're talking about the highest rate of asthma children's deaths in Europe, I mean, that's appalling for a developed Western nation like the UK. There's no way that we should be top of that list. And really, the government needs to take it seriously. We've had a lot of government schemes to reduce deaths involving drugs, involving smoking, and alcohol use. We should be saying that the death of children due to asthma is nearly always preventable, and there are often clear signs that the child's asthma is not being managed properly. So we need a national strategy, and I think it should be one of the top priorities. We're talking about asthma, which is one of the most common childhood illnesses that there is. I mean, it's extremely common, so there'd be really no reason for us not to address this at a national level. Now, I would be talking about really clear instructions to your general practice primary care team about when children should be reviewed, having a practice policy in place to arrange regular review for children who are having exacerbations of asthma, and clear guidelines on what to trigger those reviews. That'd be my recommendation.
Right.
Furthermore, good referral guidelines about when children should be considered for referral to specialists. And if that means that there's going to be more referrals to secondary care as a result of this, then so be it. And if we need to recruit more respiratory physicians, or pediatricians as a result, then that might need to be done, and that will cost money. But if it's going to prevent excess children's deaths, then that will need to be done.
I was going to that as with so many other fields in NHS, we see the lack of funds is a huge issue. So increased funding in this regard is going to be, I think, one of the main factors, because we don't have trainings, we don't have clinicians, we don't have people who can monitor this, then it's going to be a huge problem.
No, exactly, and it's a controversial thing to talk about money. There is a lot of money in the NHS, and we think we talk about waste of money. I think that the death of children due to asthma is a good use of public money, and I don't think there'd be anyone who'd really object to me saying this. I think this is a good use of money, and if it costs more money in order to train more pediatricians, respiratory specialists, or maybe GPs with a specialist interest or a specialist nurse in the treatment of asthma, one of the most common children's conditions, I think it's a good use of money. But we'll leave that to the politicians to agree on or not. But I agree. I think that's something that we need to address.
Yes, no, definitely. I mean, it's the politicians who eventually decide. But I don't know, personally, as a doctor, I do feel that should be highlighted, because that's where things do end up. But thanks a lot. And so in summary, I think what I would just like to point out is that if a child has multiple asthma attacks or severe asthma attack, it's a sincere request to all the parents to get it referred, to get it checked by the asthma specialist, be it GP, be it respiratory nurse or a respiratory specialist. If your child is using multiple short-acting inhalers, the blue inhalers, the relievers a lot, get it checked. Make sure that asthma is treated by a regular use of steroid inhaler. That is absolutely important because that brings down the inflammation and that prevents any further attack. That's why it is called the preventer. It's not for seasonal use, it's for regular use if you're advised, so please use it. I think that would be great. That would be it. Dr. Calder, thanks a lot for sparing your time discussing about this. And if we do get good feedback, which I'm hoping to, and if you would agree, we'll do more of these sessions. Thanks a lot.
Thank you for inviting me along today. And yeah, we'll hopefully hear from you soon.
Thank you.